Right, guys. Welcome again. This is our agenda for today. Refreshments are being set up. We'll have some time later on for you guys to eat. We ordered spaghetti and meatballs and salad and garlic bread from Panera Bread. So wanted to feed you well, as we are basically having our first meeting since COVID in person for our monthly meeting. So this is a big deal for us. And we're trying to make hybrid happen at the same time. So thank you again for your patience. So we're going to have our East Flatbush Community Partnership updates as well as past events. Amy did share briefly, and then we have some presentations as well, and then we'll leave some time for your program updates. Okay, so we're going to continue on with our East Flatbush Community Partnership updates, and Cindy will lead this section.
Hello, everyone. Again, she said Cindy Reed. I'm with the partnership here. So you all know that we have a weekly newsletter that we share on Wednesdays. So we encourage you to send any flyers that you have for any upcoming events, resources, and stuff that like that, so they can be shared. And it is well received in the community. We get so many compliments where people are like, oh, that newsletter is full of so much information. So share your stuff. Email is reidc@jccany.org. Okay. And we also include on the newsletter a link that if you want to sign up to be a presenter, you can sign up to present on future meetings. Sorry about that, Kai. We also have a community resident liaison opportunity right now where residents within East Flatbush, within the zip codes of 11203, 11210, and 11212 and 11226, living in those zip codes for this opportunity, they're eligible to living in those zip codes. Sorry. We prefer Creole and Spanish speaking, but they don't have to. It's just helpful when communicating with the community. No education requirements, and some of the benefits that comes with that is a $250 stipend every 3 months. MetroCards can be provided as well. Opportunity to develop your leadership skills and gain experience with communicating, developing a community coalition. We have our open door meeting that is virtual, that happens on the second Thursday of each month at 7 p.m. This meeting is mainly attended by residents. We started it at 7 p.m. at a later time so that residents can get the great information that we share during the general meeting from 3 to 5. So that meeting is virtual. If you want to present, you can let us know, but we share that with the community on, I think April 11th is the next day. Our journal meeting, which you all are here for right now, happens on the 4th Thursday of each month from 3 to 5. So thank you for being here. We encourage you to visit our beautiful website, which is eastflatbushpartnership.org. We share a lot of information that you share with us on there, and then our information is on there as well. Thank you.
Hi, good afternoon. I have a question about the
Good morning, everybody. My name is Kai Pereira. I'm a community ambassador here at East Flatbush Community Partnership, and I'll be bringing you our past events. On March 9th at PS 109, we had a youth symposium. Can somebody help me? Symposium, my apologies. An annual youth symposium. It was a day of community empowerment and lots of fun. It empowered the youth to utilize their creative abilities to lead, serve, and influence change locally and globally. On March 16th, we had our community wellness check calling out all older adults and veterans. It was from 12 to 2 o'clock. And we gave out free new or generally used clothing, coats, shoes, sneakers, boots, and refreshments. We had many resources there, such as wellness check, insurance, home care, SNAP, and self-care awareness. We had many supporters come out, such as Campbell Sunnyside, Downstate Hospital, Health and Wellness, and many others. On March 16th, we had our Youth LED conference. It was for entrepreneurs and small businesses, led by Assembly District woman Monique Chandler Waterman at 903 Utica Avenue. Thank you. These were all partner events that we tabled out. Our community, I'm assuming another partner event that we tabled out. A community baby shower. There was a conversation with maternal and child health experts. We had diaper distributions, children activities, community resources, and light refreshments. This was on Saturday, March 23rd, from 11 to 1. I'm pretty sure it was a great event. We had a resource fair, tabled at a resource fair, March 25th, from 3:30 to 5:30. It was a single parent resource fair designed to connect single parents with valuable resources and services within our community. Pretty sure that was a wonderful event too.
Thank you, Kai. So we mentioned open door. Our next meeting would be on April 11th at 7 p.m. So we encourage you to share that with your family so they can join us. We have some a great presenter ready for that meeting that day as well. And our next general meeting, don't know the date for next month, but again, it always falls on the fourth Thursday of each month from 3 to 5. Everyone that's in joining us via Zoom, thank you so much. We encourage you to type your name and email in the chat if you're a resident, just to let us know that you're here. And if you're a service provider, do the same, including your name, email, and organization as well.
Good afternoon. I'd like to introduce our next speaker, Abby Ambush. Abish. You went, okay, I'm sorry. Abby Amy. I'm so sorry. The AVP of Behavioral Health and Wellness here at JCCA. And
Hi, everyone. I'm Abby Jeffrey. I'm the AVP for Behavioral Health and Wellness Programs here in the city. We do serve all 5 boroughs, but we're going to be talking specifically about the programs for Brooklyn. I do have some people from our programs here to help me talk about the different programs. So first, I'm going to introduce Sylvia Bonet, who's going to talk about our health home program and our non-Medicaid care coordination program. They're both similar, but it depends on what kind of insurance the client has. I don't know if this...
Hi. Oh, okay. So, yeah, good afternoon. My name is Sylvia Bunai. I'm one of the outreach intake coordinator for the Brooklyn office, but still, when we receive the referrals, we receive for the 5 boroughs. We are 3 intake coordinators. So, what is a health home? Majority of people think that the health home is just like a home when the clients go there, right? But the health home, it's basically a care management program where we serve children from 0 to 21 years old. The goal of the program is to support the child and the family in getting access to community services, make medical appointments, to follow up in any issues, that the child is experiencing, and also provide them with resources as well in the community. If there's any issues in the school, there's a care manager that can attend to meetings, follow up with all the providers involved in the child's life. In order to qualify for the health home program, the child either can have a mental health diagnosis or 2 chronic medical conditions, for example, asthma and obesity, or and also the child can have HIV, if not sickle cell. If the child doesn't have those qualifications, then we can refer the child to be evaluated for a complex trauma evaluation, which it means that if you see that the child is experiencing any behavioral concerns due to a specific trauma like domestic violence or any other trauma, then we can send that referral to our OLP team for the child to be evaluated and the child can be enrolled in our program. The way how it works is that once the child is enrolled in the program, they receive a care manager. This person go to the home or go to the school, follow up with the family, and then within, that the meeting, they can follow up in any specific needs that the child might have. The program is a freedom of choice. Basically, once the child enrolls in the program, they can stay until the age of 21 years old, or they can disenroll from the program at any time. And then they can also come back to the program at any time, if they qualify for the program. So we serve, all the clients, all languages. If the care manager doesn't speak the language, we use translation services, but we do help, the families. Yeah. So, in terms of the non-Medicaid program, the non-Medicaid program is for children that do not have a Medicaid or they have a private insurance, but they do have a mental health diagnosis. Once, we have that, we complete the paperwork and the children can be enrolled in the non-Medicaid program and they receive care coordination services. The same thing, worker that can follow up and everything related to the child's needs, concerns, meet with the family at home, in the community, in the schools, just to support them with everything that they need. In case the child, so we receive referrals from CS4. Once, we receive the referrals and the family accept the program, it's very easy, we can enroll them once the family are ready. If we receive a referral from outside, then I complete the CS4 referral, and then we gather all the paperwork that is needed, and then we send, the paperwork to CS4, which that might take at least, 1 month. But we always trying to find ways to help the clients to, qualify in the program. Any questions? I don't know.
They have to be.
Oh, the age. Yeah, before 21, from 0 to 21. Yeah, if they turn in 21 and we enroll them today, yes, we can do that. So. Yes. Electronically, we can send you, yeah. And also, with the referral form, we can send you that. Okay, any other questions? Okay, so and also part of the Health Home program, we also have the second part, which is the CFTSS services and the HCBS services. Once I'm enrolling the family in the Health Home program, if the family decided to accept the second part of the program, then that becomes which can be it's gonna explain.
Hi, I'm Kimberly Trenzo. I am the OLP supervisor and currently covering HCBS for CFTSS and HCBS programs. CFTSS stands for Children and Family Treatment and Support Services, and HCBS is Home and Community-Based Services.
Hi, and I'm Rochelle Noisette. I am the other OLP supervisor, other licensed practitioner, which is like counseling services, therapy, basically, under the CFTSS program. And I supervise all the therapists that go out into the community or do telehealth services for the children in our program from 5 to 21, but it's really like the day before their 21st birthday, because unlike on health homes, we don't go beyond the 21st birthday. So they age out at age 21. So I'm gonna pass it to Kimberly so she can talk about the evaluation.
So as Sylvia says, I work very closely with Sylvia and her coworkers when we get referrals for our programs. Right now, technically we do service 0 to 21, but we do try to do at least 3 to 5 because the child is involved in our services. So we want to make sure they're capable of speaking or engaging in the service. It's really important to say our service is voluntary. This is not a mandatory program. So the parent or caregiver that has legal rights must be the consenter for the program. And our services is a little different than a clinic because we're supposed to go where it's best for the family, whether it's in the home or the community. We're also doing telehealth. Instead of the family having to come to us, we are supposed to meet their travel needs. So our program has a lot of acronyms. It's very confusing. So we do have pamphlets. I notice it's best to just give a general summary, but I believe that you could maybe email the acronyms to everyone who's here. I think that might just be easier. So we do offer therapy services under Rochelle's Workers. These are licensed social workers, mental health clinicians who provide individual, group, and family therapy. We also have individuals who do crisis counseling, psychoeducation, social skills, daily living skills. Each service also, I forgot to add, has a different enrollment criteria, which is what we do in the beginning. Some require a diagnosis under the DSM, some do not. So those are the services we are providing right now under CFTSS. We do have two other services, which is family support and peer support, but currently we don't have any providers. So if we do get any providers, it's really to support the youth with learning, you know, how to transition into adulthood with someone who's of similar age, and you have to be 14. And the family is an individual who has life experience in assisting with resources and advocating with schools. But I said, unfortunately, right now, we don't have any workers for those two.
Yeah. No, be able to provide that service.
But the therapy in the crisis counseling, psychoeducation, social skills, and daily living skills, we do have workers for. Home and community-based services, you have to be enrolled in health homes to qualify for that program. The most popular service, which maybe you've heard of, is respite, where the workers take the youth out of the home to get a break and to regulate their emotions in a healthy manner. We also have pre-vocational service, which is 14 and over, to help youth learn how to interview writing, resume skills. We do also have a service called CFAS, which is Caregiver Family Advocacy Support. Like I said, there's a lot of acronyms. And that is specifically, again, for the family. It's again to help the parent and the caregiver learn parenting skills, learn how to communicate with the school. Also, if they need any resources, they would help. Do you think I missed any services?
To be eligible for the service, the client must have Medicaid. We don't have a non-Medicaid program, you know, so it has to be a Medicaid, a managed care Medicaid. And they have to show, there must be a need, like a risk, a concern, to be eligible for the services. I think we, yeah, you must show.
So we get a referral mostly from the health homes program. I've had made some other connections with visiting nurse or just some other locations that send us referrals. Once I get a referral, we do check to make sure the insurance is active, and then I assign to one of our staff. They do call the family, or if it's a youth with a child, they are their own medical consenter. And we would call them, we would explain all the services in detail. We could say how this would assist them, and then we would ask them if they would like to move forward with doing the intake, which is a psychosocial, a lot of background, social background, education, and your behavioral background is what we would do with them. And we would have to ask after everything is explained if they're interested in moving forward. As long as their parent consents.
because they're not 18 yet, they won't get the medical consenters. So the caregiver, the legal guardian, whoever is the medical consenter has to complete the referral for them.
So mostly that is a larger part on the health homes team that most of our clients are in health homes and they do prepare when they're aging out. Cause for us, like we says, the day before their 21st birthday, and health homes, I believe your last was 25. 23. But if they don't have health homes, then we do try to have our workers show them different resources depending on their needs of what they could do as they're aging out. So we don't want someone to age out without, anything planned for them if that's what they.
So we work with our youth on a treatment plan or a service plan, right? So, and we do those treatment plans every 6 months to review their goals, see how they're progressing. And, if at that time of the 6-month treatment plan before their 21st birthday, let's say, we start working on the transition to, what life is after services, or what they're looking for. Do they want to be connected to another clinic in the community to continue therapy or whatever other services? Then that's, the service provider, the person that's contracted to provide the service to them, starts working on that transition to, No, not necessarily. If they come to us, they have to be eligible. They have to have Medicaid, to come to us. So let's say a family loses their Medicaid while their eligibility or they don't qualify or something happened, right? They lapse. And so, we will work with the health home team, the health home care manager, to assist the caregiver or the youth to reinstate their insurance. Our services are like direct services, is not so much as connecting it to like community providers, like the child welfare system, let's say PA and the benefits and entitlements, things like that. We don't necessarily work on those things. Perhaps a caregiver support service provider can help the family provide some information to them, but they don't directly assist them, like taking them to appointments, helping them complete those referrals. It's mostly like, well, there's this reference, you can go there and apply, things like that.
Our intake process probably takes about a month because it's 2 parts. And then they have to get matched to a provider. It depends. Kids who want telehealth are matched very quickly. If there's someone who wants in-person services, then we will look for a provider in that area. So the range can vary depending on where you live. You also have to live in the 5 boroughs. I just want to, we are not covering Westchester at this time.
It's just the fibers.
Meant to mention. We do an SP or service provider request change. And then we find them a new worker. That has happened. Not everyone matches with the first person that they are selected with. When we do the intake, and we're doing the second appointment, we do ask the family about their preferences. So that tries to help us match with someone who would be a good preference for the family, but we can change if that is what's needed. You're welcome.
So just to further answer some of the questions that were asked,
The Health Home program is the program that would help with finding other sources in the community, or when the youth reaches 21, would help them make a plan for after they're out of CFTSS, or once they want to start transitioning out of health homes. Also, if a youth comes to us without Medicaid, we can enroll them in our non-Medicaid program. And then the worker could help see if they are potentially eligible for Medicaid, whether it's under a family of one or under another means, and help them apply for Medicaid. So that is something that the non-Medicaid care coordination program can do. So now I'm going to talk about two of the other programs that Behavioral Health and Wellness provides. One is the Article 31 Mental Health Clinic, which is called Brooklyn Counseling Center. This is a traditional mental health clinic. It's right now we have one in Brooklyn, and in the next few months we'll be starting one in the Bronx. So this is for kids between the ages of 4 and 21 who are looking for therapy, whether it's individual therapy, and we can also do some family therapy. We accept Medicaid, and there's certain private insurances that we accept as well. The process for getting enrolled in the program is to come in for an intake appointment. There's, I believe it's 2 or 3 intake appointments. And then depending on the youth's needs, the youth's age, their developmental age, and how they can respond, they can either do their therapy appointments virtually or in person in this building. The therapy is provided in this building, but about half our clients are seen through telehealth and about half are seen in person. The hours of the clinic go until 7 p.m. Although there is late night. Actually, it might be every night that they can stay virtually till 8. Is it every night, Leonard? Yeah, every night. So in person, it's till 7, virtually it's till 8. Trying to think what else. We also have medication management. We have a psychiatric nurse practitioner who's on staff at the clinic. So if a youth needs medication, they can also get that through the clinic. They can be evaluated. If they are already on medication, they can come to the clinic and have it managed by our psychiatric nurse practitioner, or if they feel they may need medication, they can be evaluated by the psychiatric nurse practitioner who can prescribe medication. So they can get both therapy and medication. They can't come just for the medication management. They would need to have therapy also. Are there any questions about the Brooklyn Counseling Center? It's pretty straightforward. Okay. And the last program I'm going to talk about is our Youth ACT program. Youth ACT stands for Assertive Community Treatment. This program is for our highest acuity youth who are in the community, and it's to prevent youth with acute mental health diagnoses from going to higher levels of care, from going to residential placements, or it's also for kids who are stepping down from residential placements, or who are coming out of hospitalizations or have frequent use of hospitalizations, whether it's emergency departments or inpatient stays in the hospital. It's also for kids who have acute symptoms. We have kids with diagnoses ranging from attention deficit disorder combined with oppositional defiant disorder, all the way up to schizophrenia, schizoaffective disorder, bipolar disorder. We see the full gamut. We also have kids with coexisting substance use disorders who usually are not willing to work on those substance use disorders. This program is for kids between the ages of 10 and 21. So all referrals for the Youth ACT program are through CSPOA, the Children's Single Point of Access, but you can always reach out to us and we can help you through that process of going through CSPOA.
The kids are seen by a multidisciplinary team made up of a team leader, a psychiatric nurse practitioner, 3 social workers. We have a family peer advocate, a youth peer advocate, a case manager, and a program support. So and everyone on the team sees every kid. It's not like someone on the team has a caseload. Everyone is seen by everyone. So every kid has a chance to connect with. There's usually someone they connect with best, or 2 people on the team they connect with best, but they're given the opportunity to see all the people. So they're really getting a full multidisciplinary approach to their issues. We work with the families very closely because often the youth is triggered by their family. We find that that's often the case. Not always. We have some families that are incredibly supportive, and we have some families that are contributing to the issue. So it's a really great program. We were the first Youth ACT program to open in the city. They've had ACT programs for adults for 50 years and just got around to doing them for kids in the last 2 years. So we're very excited about this program, and it's for youth with really significant mental health issues that need a full team support. We also go into the community. We'll meet the youth at the school, at their home, at a McDonald's, wherever it is that they need to meet. We meet with the youth and the family at least 6 times a month. So it's a very intensive support for the youth and their family. Any questions? Yes. The question was that you wanted me to repeat the questions. The question was about the adult ACT teams. I don't have a ton of information, but there's different ACT teams. I know there's a specific ACT team for people who are justice involved. There's ACT teams for I know there's that one specialty for adults, and there's also just general ACT teams for adults. They start at the age of 18 and up, and they're referred through the adults. It's SPOA, the single point of access. They have a little less emphasis on therapy from what I understand, but it's again a multidisciplinary team approach. There's an actual nurse. Some of them specialize in helping finding housing. That's about all I know about the adult one. Sorry. You're welcome. It's called FACT. Yeah, forensic assertive community treatment. That's okay. Sure. So the question was around what the assertive part looks like. So the youth, when we do the intake, we do want the youth to be willing to be in the program because it's an intensive program and we want their buy-in. But while they'll say yes, they're not always committed to actually doing the program once they're in it. So the assertive part is really reaching out a lot and doing pop-ups, texting the kids, calling them, trying to see them at school if we're having trouble connecting at home, reaching out to the parent, really making that effort to make sure to see them the amount of times per month to make the contacts, to really be following up with the youth and their family to make sure they get the services. We're providing, the social workers on the team are providing therapy. So they're actually getting therapy, case management, medication management, family and youth peer support. They're getting all of those services, and we're, constantly reaching out. We set up the goal is to have contact with them twice a week at least, so that we can make sure to make the contacts throughout the month. So that's the assertive part. Sure. Yeah, so the question is, do we get dropouts from high school? And the answer is yes. We've been helping one youth get into a GED program. So our case manager and our youth peer advocate will work with the youth to try to help them in whatever way that works for them, get their education. We have another youth who's like 19 and still in high school. So helping that youth graduate. So we do get the range of issues educationally. And part of what we do is advocate academically and attend IEP meetings and call for IEP meetings and do whatever is necessary academically for the youth. And vocationally, we've helped people do resumes and apply for jobs and things like that. Sure. Anything else? All right. Thank you so much.
Thank you so much, everyone who's presented so far. Next up, we have Leonard, and Leonard is the Program Director from Helping Hands for Families, FTCR Program Preventive.
Thank you. Good afternoon, everybody. So I'll be presenting about preventive services. So my name is Leonard Lavelle. I'm the program director for one of the preventive services program, which is family treatment and rehabilitation, also known as Helping Hands for Families. So I'm gonna speak about my program first, and then I'll touch a little bit on the others in the presence of my other team members. FTR, which as I mentioned earlier, stands for Family Treatment and Rehabilitation, is an intensive preventive services program. So when you hear preventive services, think of child welfare, think of ACS, think of foster care. You know, our main goal is to prevent children from entering the foster care system. So sometimes when a family has a case called in, ACS comes, they investigate, they don't feel like the concerns are enough to remove the children, but they may feel that the family needs supportive services in the home. So when that happens, ACS usually makes a referral to one of our preventive programs. My program in particular is a program that deals with families that are with parents or children that are struggling with mental health or substance abuse. The criteria to be enrolled in our program is as long as a parent has a child between the age of 0 to 17, 18 years old is considered an adult in the child welfare, in the preventive world. So as long as there's a child in the home between 0 to 17, and we work with the family on goals in order to prevent the children from entering the foster care system. One of the things that we do, we have like a three-phase model that we follow. So initially, when the family accepts our services, another thing too, the services are not they're not mandatory in the sense of when we come, if the family says no, I don't feel like I want preventive, then it's not forced. However, there are times when it is mandatory, is when ACS gets involved and there's court involvement. And the judge may say, well, in order to keep your children home, we mandate, it's mandatory for the family to have preventive services. So those are I just wanted to make that distinction between the voluntary and involuntary of preventive services. So like, as I mentioned, we substance abuse and mental health are the main criteria in the family treatment rehabilitation program. So if a family accepts services, and we have a three-phase model, in the initial phase, we do 6 home visits, just as intensive as the team. We do 6 home visits in the initial phase of treatment. But in that initial phase, we also trying to get to know the family. So this is why we're doing 6 visits. We do advocacy as well. We make referrals to mental health providers, substance abuse providers. We do advocacy with the schools. A lot of times the children need advocacy with IEPs. Sometimes the parents don't know how to go about getting the services in school. So we're here to assist in getting those services. Also, after the initial phase, we have a team meeting, a clinical diagnostic team meeting. We discuss the family needs and what's going on. And then we determine as a team if the family can move to the next phase, which is baseline. In the baseline phase, the visits go from 6 to 4, which is basically average out to once a week, right? And then from that point, if the family's meeting their goals, we see there's the risks that brought the family to our attention have lessened, then we step the family down to stabilization. Stabilization, the visits go down to twice a month, and then at some point later, we might discuss case closure at that point. So that's the gist of the FTR program. It's the most intensive of the preventive programs we have here at JCCA. All right. So did anybody have any questions with FTR before I get a little bit with the other ones? All right. Just a little bit about the other preventive programs we have here at JCCA. So we have a child parent psychotherapy program. This program, so we have one in Brooklyn and one in the Bronx. This program works with the criteria for this program is the child has to be between 0 to 5 years old. So a lot of times, people have it confused that the children don't deal with trauma, but children do deal with trauma. And what happens during childhood impacts as they grow. So CPP, child parent psychotherapy, works on the parent-child relationship and try to mitigate some of these things and also help the parent raise the child and address these concerns. So that's that model. Typically the time frame is 4 to 12 months. It's an evidence-based model. Some examples of the trauma is maltreatment, traumatic death of someone close, a serious accident, sexual abuse, and exposure to domestic violence. So see, these are some of the traumas that affect the parent-child relationship. Right? The next one is solution-based casework, which is also known as family support. So of the preventive programs I've mentioned so far, this is the least amount of visits that occur. So in this program, it's more general needs, like if a family needs support with like educational advocacy or housing support, or a family is stressed and they just need connections to resources. This is the right program here. It's called family support, right? In this program, the social worker would visit the home twice a month. And then they'll also help the family like create a genogram and kind of help the family know, okay, what supports you have that you may not know of. So that's another good preventive program. The last two, another program we have is Second Chances. Second Chances is more of a youth-based program that we have in preventive. But this program deals with court-involved use. So these are also court-involved use and also use in the community that are at risk of being in court involvement. So it's a program for youth 12 to 17. Some of the things that we see like truancy, disruptive behaviors, maybe there's unmet mental health needs that may not be met. So Second Chances work with those youths and gives them a second opportunity, because oftentimes when youths are involved in the juvenile justice system, sometimes we kind of throw a blind eye. But so irrespectively so, that's why it's called Second Chances. We give these youths a second chance. We don't turn the blind eye, right? And the last program we have is called Brooklyn Families Together. So of all the programs, this Brooklyn Families Together is a family therapy program. A lot of times, family therapy is short-term, and this is also adolescent-based. So the criteria for the Brooklyn Families Together program is a youth has to be 11 to 17, and they follow the functional family therapy model. And the goal of this program is to model support, strengthen and empower families in order to prevent therapeutic placements and also address truancy, suicidal ideations, depression, and extreme aggression. So this is the family therapy program here, and it's also geared towards adolescents. All right. So I don't know if anybody had any questions about the 5 programs I briefly talked about. I know it's a lot. Go ahead. Right. Oh, yes, yes, I did. Yes. So 2 things. Thank you for mentioning that. So everything, all the programs I mentioned is community based, it's home based. We go to the home and do, visit the family. Yes, some of these cases do come in through ACS. However, a parent can walk into JCCA any day and say, hey, I need help. One of the supervisors, directors, whoever's here in the building will assess the family and see what's the right fit. But yes, we definitely take walk-in referrals. So yeah, so I mean the 3 of the 5 that I mentioned are under the ACS umbrella. However, we explain to the families that, we are mandated reporters. So if it does rise to that level, we might have to call ACS, but our goal is to not do that. So we'll usually work with the family. We'll have, before we even get to that point, we'll have something called an elevated risk conference where we have all the parties get together and discuss whatever's going on to prevent even getting to that point. But yeah, we try to not get ACS involved, but sometimes we have no choice. Mm-hmm. Yeah, we work with kids who are dealing with truancy, not going to school, cutting school. Mm-hmm. Mm-hmm. So well, it was, oh, I see. Oh, you're referring to like the truancy, like if they cut in school, they bring them in and do and pass them. Oh, yeah. So no, that type, yeah, I don't see that no more. Yeah. But however, if there's like a youth that's dealing with truancy and they need like short-term counseling or anything, Second Chances would be the right program for that youth. Mm-hmm. Yeah. Yeah. So what I'll do, I'll send Lamaka our brochures electronically, and I'll also send our referral forms. Feel free to send a referral. We could always assess. Like I always say, you have nothing to lose. Send it in. All right. Mhm. But yes, going back to yes, we do. I'm sorry. We do take we do take walk-ins, community referrals, schools, like we get referrals from schools, we get referrals from hospitals. Another work we've been doing lately is we've been working closely with the migrant families in the shelters. We've been doing a lot of work there. And another thing, preventive services is free. It's no insurance. You don't need insurance for preventive services. It's free. It's funded through ACS. Anyway,
Thank you so much. Okay, we have one more presentation from JCCA. We have Liza here from the Unaccompanied Children's Program.
Hi, everyone. My name is Liza, and it's really funny because I was asked to do this actually last minute because Christine Welch, our director from Home Finding, was not able to make it. So it is my understanding that last month, Lauren Glassman, our program director, did provide some information, spoke about the program. So if it's repetitive, it's okay because this is actually really good information. So I'm the assistant program director for the Unaccompanied Children's Program that we call the UC program. And it is a federal funded program by the ORR, okay? So basically, it is the Office of Refugee and Resettlement. We have children that are coming in the border. I know that you guys have seen it on television. There's been a lot of controversies. There's a lot happening there. What we do here at the UC program at JCCA is that we take the children that come in literally unaccompanied. They're alone, they're by themselves. The children that come in are between, believe it or not, the ages of 0 and 18 years of age. How is this possible? One can ask. I'm a mother, so it's like, it's really hard to fathom the thought of a 7-year-old at the border by themselves. It's hard to fathom the thought about a 5-year-old at the border who was with family, however, was separated. Basically, what happens is that we have children coming in from all over the world. It could be from South America, Central America, Africa, India. It could be anywhere. It could be for whatever reasons. It could be because of gang violence, politics, government issues. It could be over war, okay? Or it could be that the family wants the child to have a better life. It could be that the teenager wants to come to the United States because they feel that they would have a better chance of becoming a doctor, of obtaining that education, something that they can't do back home. So what we do is once the child is taken by DHS, they're placed in shelter. What happens is that that information is sent out to various LTFC programs cross country, one of which is ours here at JCCA. And so what happens is that once we go ahead and we accept the child, we place them in a foster home setting, which is kind of like long-term foster care. In terms of regular foster care, the only thing is that we don't deal with ACS. We deal strictly with ORR. The children that we have here at our program receive various services. So we provide them with case management, we provide them with therapy, we provide them with access to legal services, all of which are free. We provide them with reunification because many kids that come in, they do know who they want to be sent to. Many kids that come in actually do have phone numbers to friends, family members that live cross country. We try to reunify them with their family if deemed appropriate. Because remember, we have a whole slew of people in the government that are actually looking into these people to make certain that these children are safe. So with that being said, we work on that. Again, access to legal services, recreation, education. What we mean by education is that we do place the children in community schools. So basically what happens is that wherever the foster parent lives, that child will be placed in that particular school, okay? Whether it be regular like grade school, junior high, high school. That is where they're placed. In terms of recreation, they're always busy. We place them in after-school programs. We place them in summer programs. We place them programs during the weekend. What does that entail? Whatever it is the kid wants to do. Many of them want to play sports. We find them a program that will provide that for them. Right now, we have a child that wants to play the accordion. We found a teacher that will give lessons for the accordion, you know? I mean, that's what they want. So everything is per what the child wants. We provide tutoring services. Not the agency ourselves, but we do contract out for tutoring services for any additional help, math, language, social studies, science, whatever it is that the child needs assistance with, we provide that. We provide English services as well so the minor can learn English. We have an educational specialist that is deemed to actually directly work with the child's schools to make certain that our kids don't fall in between those cracks. We advocate for our children and we make certain that they obtain what they came here to the United States for, what they want, what they need, and what they deserve. So that's just a little piece of what we do. Again, in terms of permanency, we're always trying to get these kids back with their families within the United States. So that's my program, which I'm very proud of. I've been working this program for at least 3 years. And we're very excited because our program has expanded. We started out in the Bronx. Now we are in Brooklyn and we are in Queens. And you never know what could bring forward, in the future. You never know where we're going to end up. But this is a very good program. We are in need of foster parents. We are in need of foster homes in Brooklyn and in Queens. We're looking for all families, Spanish speaking, families that speak only English, families from the Caribbean background, We're looking for families that are willing to open their homes to our children. Do you have any questions? Yes. Who's first? Who's first? Okay. Go ahead, Keisha. So basically, that's a really good question. Okay, our foster parents, we go through the guidelines of ACS, through state regulations of OCFS. However, the training is different. Our foster parents are required, I believe it's 44 hours. 44, it's 40 or 44? It is 44. It is. And the reason why I got confused there is because ORR is always changing the criteria. That I have to let you guys know. They're changing the criteria. It's the government. So they are required 44 hours of training, much of which we do internally. We do have a foster parent coordinator here who does provide training to our foster parents, and much of which is actually online, or rather virtual. Reason being is because many of our foster parents work. So we want to make sure that we work around the foster parent schedule. It's a number of trainings that I can't even begin to tell you, like per training. However, I can go ahead and I can send that information out because it is a lot of trainings. It could be a single home. It could be a 2-parent home. We're very open, to that. Basically what happens is that we have a person who will go into the home from JCCA, from our home finding department, and they will go over the policies. They'll go over, again, the program and what is expected. And, from there, again, you're going to have your trip training, which is something that is mandated through ACS. That I know for a fact, every foster parent has to have that training, including other trainings, which you can get actually within that year. There's certain trainings that a foster parent can obtain every 2 years. That's the reason why it gets a little bit confusing. But yeah, you don't have to be a 2-family home. It could be a 1-family home. Mm-hmm. Yeah. What's your name? Yeah, thanks. Yes. Uh-huh. Mhm. So basically, every foster parent, they have their own age requirement. Okay, so they can choose gender, whether they want male or female, and they can also choose between the ages. We have our tender ages, which are between the ages of 0 and, let's say, I want to say like maybe like 10, 11 years old. And then we have the older children up to the ages of 18. So it's up to the foster parent. If they have children that are living at home, that's not going to jeopardize the foster parent from obtaining children. It's not. If anything, it actually makes it better for the child because it puts them in that family setting and they become a part of the family. They become a part of their family events. So we actually really, really want that. We're pushing for that. So basically what happens is that the Department of Education, right? Once we go ahead and we let them know that we have a minor that we're looking to place in school, depending on the actual school district of the foster parent, they only ask, believe it or not, the age. They place the child in the grade that connects with the age. Now, I know it sounds harsh, right? Because they're coming in from somewhere else. Many of our children, they don't go to school at all. So what happens is that we have our educational specialists, myself, the case manager, all right, the clinician, we all get together and we advocate for the child. Many of our children, they do need to be evaluated and assessed, and the schools understand that. And then from there, they're placed in the proper educational placement or grade. But at first, it has to do with the age, which is something that the DOE does across the board. So I know it's a little rough. Some kids do come on a plane and they do land, maybe let's say Mexico, because that's the border. Some kids actually walk from their country of origin. It's kind of hard to say. So I can talk about, let's say, one child, right? He was, let's say, about 15 years old. This is a minor that came in many years ago. And he's actually very successful in the program. And his story is that he came from the Congo, all right? And he had to cross various areas. He had to cross many jungles. He had to take cars. He had to take buses. He had to walk. And he had to stay in various other countries in order to be able to reach Mexico. So that's why I'm saying it's kind of hard to be able to talk about just one specific situation, because we have kids that go through so much. Some kids actually just come in a bus and they'll stay on that bus. They'll get off the bus somewhere in Mexico, and then they'll sleep in a bodega, like in a store. We've had those stories too. And then the following day, they'll go to the border. And then that's when they get apprehended. So we have those stories too. You know, some stories are very tragic and some stories are not. But these are children that are coming in from all around the world that have a very significant, very delicate past. And they've been through a lot. And let me tell you, when they come, they're so intelligent. I mean, they know the ins and outs. They're fascinating. They are fascinating. So I wish I could be a little bit more descriptive with that question, but that's the best I can do for the moment, because it could be anything, everything. Yes, so basically what happens is that once the minor becomes 17 years of age, one thing I do have to make clear is that we cannot accept the minor over the age of 18, okay? Why? ORR just doesn't accept it. So what happens is that once the minor becomes 17 years old, our case management team is already speaking to the minor about permanency in terms of what it is that they want to do, right? Do you want, like, say, for example, they don't have a sponsor. They have no family that will take them. What is it that you would like to do? Where do you see yourself once you turn 18? So there's various options. Depending on the minor's, let's say, past, we can apply for OTIP, which is for children that have been trafficked. We can apply for that, where if they're approved, they go into URM program. That program will take them from the age of 18, I believe, up to their mid-20s. And they will help them with college, they'll help them with their legal status. It's a very, very good program. There's various programs that are URM across the country. That's one option, only if they are eligible for it. Then we have another option where if they want to continue with the program, we can transfer them to ACS custody. So they will become a part of the regular long-term foster care system, where they will be placed in an ACS foster home setting, and they will be provided with immigration services, grants to go to college, many more support systems, medical, dental, everything that they need will be provided through the state of New York. If they decide that's the choice that they want, we start working on placing them. Now, remember, this is before they're even 18. We're already working on this by the age of 17. So they could decide that. There's some children that want voluntary departure. Some kids do go back home. So we can work on that. There is another option for females that that they don't want anything having to do with ACS, they can apply for OTIP. So what happens is that there's various like shelters that would take them at the age of 18 and across the country. One of them is here in New York. That's another option. Or they can be discharged on their overcognizance, meaning that they're on their own. I still have, you know what? We have one child who's thinking about it, but she ended up going to shelter. But remember, all of this is done throughout the premise of them speaking with their attorneys. Their attorneys are very, very, very close with their clients, with our children, and they help them to make those decisions, whatever is in the best interest of the child. I know. I'm on Zoom. Am I really on Zoom? Oh, nobody told me I was on Zoom. Oh, what's here for? I'm like, we might be monitored. Okay. Oh my God. Okay. Go ahead, Zoomers. Go for it. No, right? Amy, no. That's a very good question. Can the foster parents, or rather, do they need to be United States citizens in order to become foster parents for our UC program? I really don't think so. I've never had anyone ever ask that question. We've never had any issues with that. Understand that our foster parents are coming from other countries as well. So no, because remember, we do go through the ACS, OCFS policies. No. So basically what we do is as a team, right? So the team consists of education specialist, case manager, clinician, lead case manager, which is the supervisor, lead clinician, again, which is the supervisor, our program director, which is Lauren Glassman, and myself, together with our case coordinator, who is from a contracted agency through the federal government called GDIT. We also have our FFS, which is our field federal specialist. So for all the ACS people here that know about regular child welfare, they're kind of like an FCLS for the kids. They represent the children. And so what happens is that we have case staffing once a month, and we discuss these cases like, and on a continuum, like in pure detail. So we have that. We also have our foster parents that have our foster parent support groups, which is once a month as well, where they actually speak with our foster parent coordinator about any issues or even concerns about, let's say, the program, about the agency, whatever it is they want to talk about. They're totally supported by us. So we talk about that. That is something that we do once a month. However, we have an open door policy. They can come to us at any given time. We don't really have placement preservation conferences. However, we do have conferences where if a foster parent is having problems, let's say with the minor or vice versa, we do have meetings together with the clinician, and we address those concerns and we create plans as well. So that's something else that we do. We're always in connection, guys. We're always in connection with our foster parents and vice versa. Is the child able to talk about Yeah, actually, that is the main, I'm happy that this was brought up. Can our children speak to their families back home? Can they speak to their loved ones, whether it be kinship or non-kinship? The answer is yes. It is an ORR mandated policy that regardless of what the situation is, if a minor wants to call home, they can call home. If anything, they have a minimum by ORR policy of 50 minutes per week, a minimum 50 minutes. to call their family, which means that the maximum, there is none. Every foster parent knows that the children have the right to call their families and their friends back home. And we do that. Whether they can do that in the foster home or they can do it here. We can actually do it via Zoom. We can do it via WhatsApp. And once our kids are here for 3 months, if let's say they're doing great, right? They're going to school, they're really, really doing awesome. We give them a cell phone and they can make those calls themselves. I know I got a weird look over there. I did. And you know, not for nothing, when I first came to this program, I did the exact, I went, what? But they are closely monitored with who it is that they're calling. We make sure that they are monitored. So they can't just call whomever. We got to know who they're calling. At the age of 13 and up, yeah. But remember, they got to earn it. They have to earn that cell phone. They got to be good. Mm-hmm. Yeah. Oh, yeah. You got the family link? Yeah. Oh, we track them. Mm-hmm. Mm-hmm. Yes. Yeah. Yes. Yes. Yes, the child has to have their own room, guys. That's the one thing I have to say. Every foster parent, again, we're going through OCFS rules and regulations. The same thing that ACS wants is what we need to have. And ORR does know about this. They need to have their own room. The room has to be spacious. Okay, remember, we have somebody that goes into these apartments and they clear them. And if there's any issues, then they'll talk about whatever concerns there is, and they will assist the foster parent in making it right. But they need to have their own rooms. No fake walls, like you got one back there. No, that does not, no, we don't do that. We do not provide furniture. Well, let me just clarify that. So let's say in this particular scenario, you have your one son, right? Then that means that if the room is big enough and you can fit another child in there, you will be able to, let's say, request to have a male share that room with your son. That is something that we can look into, okay? But we got to make sure that the room is big enough for both children to be able to feel comfortable and not like in a small room where they're all cramped up because, yeah, that's not acceptable. But again, understand too, like I said, it's per OCFS policies. And when we have our home finder go into the home, you know, they'll be able to assess, they'll be able to evaluate, they'll be able to talk about any forms or types of concerns. How do we get to fix this? You know, let's work together. You know, so those are things that is definitely discussed in the actual evaluations and the assessments. Okay. Well, thank you, everybody. I'm going to place some information. Thank you.
Now that she knows she's on Zoom. So thank you so much to all of our presenters. I do have one quick announcement before we take a break to eat food. Just wanted to let all of you know that JCCA has a stakeholder advisory group, and they are looking to add more members to that group. The purpose of the group is to make sure that there's a deeper understanding between JCCA's leadership and the communities that we serve, to provide information and feedback to leadership about services, outcome, and the perception of the agency. And the commitment for being a part of this group is that the people will be agreeing to meet quarterly And the topics that will be discussed are JCA's policies and procedures, our strategic plan, our DEI work, as well as just overall implementation of services. So if there's anyone here on Zoom that may be interested in serving in that capacity, feel free, you can email me and I'll make sure I connect you with the appropriate person. Okay. So on that note, I'm going to just say thank you so much to everyone who came. We are going to have our program updates, but we'll do it within the room. And those of you on Zoom, you can definitely put your program updates in the chat. And what we'll do is we'll share them out when we provide our meeting minutes. But for now, we're going to end our meeting. I thank you everyone for coming. I do want to have Gilda come up. I'm sorry. Yes. Yes. Really quickly. Just really quickly. So Gilda is one of our community resident liaisons. Come over here so Zoom can see you. And I wanted to just say thank you. She is one of 4, and she served a great role as a community resident liaison. And this is going to be ending their cohort. So I just want to say thank you for taking the time out to serve with us. We really appreciate you.
Thank you for having me.
Great.
It's an honor. Thank you so much.
Thank you. All right, everyone. So enjoy your day, and we're going to have our food and Zoom. We'll see you guys next month. Thank you.